Hello and welcome to this That in Conversation activity. My name is Laura Fox. I'm hematology at the Valdebron University Hospital. I'm joined today by Professor Claire Harrison, who is Professor of Myeloproliferative Neoplasms at the Guy's and St Thomas NHS Foundation Trust in London, UK. Together, we'll be discussing management of cytopenias and the path to transfusion independence for patients with myelofibrosis. In this section, we'll be discussing the burden of disease in our patients with myelofibrosis, particularly those with cytopenias. So let's first take a look at the impact of anemia and thrombocytopenia on survival and quality of life of patients with myelofibrosis. Myelofibrosis is an heterogeneous disease with a wide spectrum of symptoms and signs that can be present as a proliferative disease or as a more cytopenic or myelodepletive phenotype. Moreover, a patient can present at the same time some characteristics of a myeloproliferative phenotype with a severe anemia. That's why this is a spectrum more than a category. Cytopenias are a distinct feature of myelofibrosis. So cytopenia is a distinct feature of MF. At diagnosis, we can find anemia in almost 40% of patients. Between 10 to 20% will be transfusion dependent, and around 50% will have a moderate thrombocytopenia. But almost all patients with MF eventually will develop anemia and thrombocytopenia, sooner or later during the disease course, and these cytopenias will have a clinical and prognostic implications and often conditionate how we treat this population. Patients with a predominant cytopenic MF will have a poorer overall survival and a poorer also quality of life compared with those with proliferative forms. These patients often experience a significant burden of symptoms such as fatigue, abdominal discomfort, bone pain, sometimes bleeding. For example, also we have to take into account the transfusions that bring complications such as iron overload, also increased risk of infections, but overall, a huge annual transfusion-related time burden for patients that adds to the disease burden that they already have. This highlights why achieving transfusion independence has become one of the major therapeutic goals, not only to improve the clinical outcomes that we already talked, but also to help the patient to regain a sense of normality and independence in their daily life. So, Professor Harrison, let's take a look at some questions submitted by our audience on the impact of anemia and thrombocytopenia in our patients with myelofibrosis. The first question we have is that in what ways do transfusion dependence and cytopenic-related complications affect daily management decisions and long-term outcomes for patients with myelofibrosis?
Sure. Laura, I hope it's okay if I call you Laura. I think, as you very nicely explained, cytopenias are a key feature of myelofibrosis. They're one of the diagnostic features. But unfortunately, the presence of anemia and thrombocytopenia, which are the commonest cytopenias that we see, do have significant impacts on patients. Let's deal first, perhaps, with the most difficult one, thrombocytopenia. So this often can cause problems with treatment selection, and we have very few treatments that impact thrombocytopenia. So we would rarely see this improve for our patients. Yet it also significantly reduces the dose of drugs that can be given quite frequently to patients. For anemia, we do know that some therapies can impact the course of this for our patients. And as we'll discuss, we know that these interventions are often better delivered as early as possible. But that unfortunately is also not the case for thrombocytopenia. When it comes to anemia, it's more common, and we know quite a lot about how it impacts on quality of life for patients. For example, studies comparing patients that are requiring transfusions to either a lesser extent or a greater extent, so formally meeting a definition of transfusion dependence. These patients often have a higher symptom burden, but also when we ask them questions about impacts of care on their day-to-day life, their emotional, physical, financial, etc. well-being, we find, perhaps not surprisingly, that these patients who have a heavy transfusion requirement often have worse outcomes in terms of those parameters. We know that both anemia and thrombocytopenia have a poor prognostic impact, shortened overall survival, but by improving particularly transfusion dependence, we can change that trajectory. And finally, just to say that there can be a significant mismatch, as I'm sure you've observed in your practice. Sometimes patients can have big requirements for transfusion, and we can improve that, but the symptom burden may not change for patients. Alternatively, we can give a treatment, make a patient more anemic, but they can actually feel better. I'm sure you've probably seen that in your practice as well.
Yes, of course. Very interesting. And we have another question is, how can transfusion independence and splenomegaly reduction improve long-term outcomes in patients with MF?
Well, in the last decade, we've learned with the application of JAK inhibitors that spleen and symptoms are improved with these agents. And we've also seen that reduction in spleen size correlates with survival benefit for patients. As we've had newer agents that address spleen symptoms and anemia, we've also been able to see a correlation between improvement in transfusion, so patients becoming transfusion independent, and survival benefit. Furthermore, interestingly, even in patients who, for example, have a 50% reduction in their need for transfusion, so they're still requiring transfusions, but less so, this also has a close to significant benefit for overall survival. Of course, also, as we've already touched on, the impact of receiving transfusions in terms of time in hospital, quality of life is significant. So any reduction in that burden is also important.
Absolutely agree. In the third question, we are asked what evidence supports early recognition and management of anemia and thrombocytopenia in influence the disease trajectory and survival in patients with myelofibrosis?
Yes, that's a great question, isn't it? I remember as a resident doctor being told by my boss, you know, don't sit back on your laurels, treat early. And actually, sometimes we wonder, what's the evidence for that? Well, we clearly know that delayed intervention for patients, for example, with myelofibrosis who would meet criteria for use of JAK inhibitors can lead to a delayed survival benefit. So ideally, patients will benefit more if we treat within the first 12 months of diagnosis. That's some evidence that comes from the COMFORT studies. But we also know that we can, for example, give better doses of drugs if patients are not so anemic or so thrombocytopenic. And then finally, as I'm sure you've observed, we've all observed indeed in clinical practice, it's more difficult to reverse problems like transfusion dependence and significant anemia if a patient's had this for a long time and they've had a lot of transfusions. It's probably because the disease is more severe, but there's also all of the extra damage that comes along with repeated transfusions, such as you've already mentioned, iron overload, for example.
Absolutely. I think we are having every time with every other JAK inhibitor kind of the same information. Okay. Thank you. And to summarize this first section regarding cytopenias, we have a clear idea that especially anemia and thrombocytopenia are defining features of myelofibrosis, strongly influencing both disease burden and the prognosis. So early recognition and the proactive management of these cytopenias enable a more individualized treatment decisions and improve the long-term outcomes. So many thanks to Professor Harrison for her valuable insights. And thank you everyone for taking the time to join us and be part of this discussion. In this section, we'll be discussing JAK inhibitor treatment, both current and emerging monotherapy and combination strategies. As we know, JAK inhibitors has transformed the management of myelofibrosis by directly addressing two of the major clinical challenges, who are splenomegaly and symptom burden, by targeting dysregulated JAK-STAT pathway. These treatments can significantly reduce the spleen size and improve the patient's symptoms such as fatigue, night sweats, abdominal discomfort, independently of the driver mutation this patient have. Several JAK inhibitors are now available, not in every country, and they have a distinct profile in terms of efficacy, in terms of safety, and also the hematologic tolerance is different between them. So we have the first JAK inhibitor approved was ruxolitinib from more than 10 years ago for both FDA and EMA, and it selectively targets JAK1 and JAK2 and is indicated for patients with a platelet counts above 50,000. Ruxolitinib remains the standard first-line therapy, particularly for those with higher platelet counts, obviously. Ferutinib, it's been approved by EMA in 2021, but a couple of years before by FDA. This JAK inhibitor selectively inhibits JAK2 and additionally has activity against FLT3. It's suitable for patients with platelet counts above 50,000, the same as ruxolitinib, and has been used in first-line therapy and also after ruxolitinib failure. The other two JAK inhibitors we have been using are pacritinib and momelotinib. These are JAK inhibitors specifically for patients with a cytopenic phenotype. Pacritinib was approved only by the FDA in 2022, and it stands out because it specifically is indicating for patients with severe thrombocytopenias, those patients with a platelet counts down below 50,000 platelets. It inhibits not only JAK2, but also IR1 and ACVR1, offering a possible anemia improvement for these patients. And finally, momelotinib was approved by EMA in 2024 and a year before by the FDA. It targets JAK1, JAK2 as ruxolitinib, but also ACVR1. It's dual mechanism. It's not only control the splenomegaly and symptoms, but also can improve anemia and also gets transfusion independence, making it a special valuable option for patients with cytopenic myelofibrosis. Overall, these agents provide a more nuanced treatment landscape, allowing us to individualize the therapy based on the platelet counts and the hemoglobin levels and the overall patient profile. Let's see the first question. What outcomes are associated with JAK inhibitor treatment in patients with NF, particularly those with anemia?
Okay, well, all JAK inhibitors are approved on the basis of their ability to reduce spleen size as measured by spleen volume reduction and to improve symptoms as measured by our standard tools such as the total symptom score or more conventional tools such as EORTC, QRQC30. And roughly for all JAK inhibitors, we would expect around 30% of patients to achieve the target spleen length reduction, and roughly the same proportion, 30 to 40%, to achieve a 50% reduction in the total symptom score. And all of the trials have shown this, and we haven't really compared the JAK inhibitors except for in the Simplify-1 study, where really ruxolitinib and momelotinib were roughly equivalent. In terms of overall survival for patients, that requires a longer follow-up in clinical trials. And so this was first demonstrated in the COMFORT studies for ruxolitinib with around a 30% reduction in risk of death, and has been demonstrated also for momelotinib linked to transfusion independence and pacritinib linked to spleen reduction. So for ruxolitinib, we expect to see that patients who are going to have a survival benefit will also have a reduction in spleen size, which cements the spleen as one of our targets. But you asked me specifically about outcomes, especially for patients with anemia. And as we've been discussing, anemia is really problematic for patients. But interestingly, all of these drugs can improve hemoglobin. For example, around 20% of patients with anemia in the COMFORT studies achieve transfusion independence. And this was also seen in a small number of patients with fedratinib treated in the Jakarta study. But for both momelotinib and pacritinib, anemia benefits are significant, especially as measured as transfusion-dependent patients becoming transfusion independent. So we would expect that to be attained by roughly 25 to 30% of patients treated with both of those agents.
And this response, this anemia response, also we can link it to the overall survival. That is something that we are starting to see with the studies performed with momelotinib and pacritinib.
Absolutely. And as we touched on earlier, quality of life is often linked to anemia for patients. That's a really good point.
Okay, so we move to the second question. What are the most common and clinical significant side effects of JAK inhibitor therapy, and how can this be managed or mitigated?
So all JAK inhibitors, as you mentioned, target JAK2. Therefore, we expect to see hematological toxicity. Although we've just been talking about improvements in anemia, which we can see with all of them, we also see a worsening of anemia and thrombocytopenia, and to a lesser extent, neutropenia with all of these drugs. All of them also carry a warning for cardiac events and thrombosis, although these warnings are less marked for patients with myelofibrosis and other myeloproliferative neoplasms treated with these agents. All of them also carry risks of worsening infection, and for each patient, you must, for example, screen them for hepatitis B, C, HIV, think about TB, and put in place management for herpes zoster. What do you do in Barcelona, for example, about herpes zoster for your patients, Laura?
Well, if usually we have enough time to prepare the patients, so we start the vaccination first. It is 2 doses, so we need to do it quickly. We have a quick program that is 1 dose and the next one to the next month. So at least the first dose, we try to give it before starting the JAK inhibitor treatment.
Okay, and then I think it's also important then just to highlight for each of these drugs, there are specific things that we need to think about. So we touched on infection and secondary malignancy, especially skin cancer. For ruxolitinib, there are warnings about progressive multifocal leukoencephalopathy. For fedratinib, there are warnings about Wernicke's encephalopathy, so you must be thinking about thiamine supplementation. You have to also think about gastrointestinal toxicity, elevations in creatinine, and rarely uveitis. For pacritinib, there are warnings about prolongation of the QT interval and need to do cardiac monitoring. And for momelotinib, headaches, dizziness, and neuropathy. So it's really important to be aware of all of those specific issues for individual patients.
What key factors need to be considered when using a JAK inhibitor in patients with cytopenia?
So remembering that for all treatments that we give, we need to decide what is the key thing that we need to treat for the patient and agree that with the patient. So it may be the big spleen, it may be the symptoms, it may be the anemia, for example. But we need to think about the different effects of the drugs, how we need to dose the agent, and that's mainly based on the platelet count. So if the patient's platelet count is below 50, the only agents we can use according to label are pacritinib and momelotinib. if the patient's platelet count is a bit borderline, 50 to 100, while we can use ruxolitinib and fedratinib, we know that the platelet count will drop. So we may need to think about things like anticoagulants, etc. And then otherwise, I'm really thinking often about the patient's ability to tolerate anemia, as well as the other very specific side effects that we were just discussing, such as gastrointestinal toxicity and nutritional status, for example.
So the short answer probably would be like to find the right JAK inhibitor for the right patient. So we need to know a lot about the JAK inhibitor we are using and also about the patient to make things work easy.
Absolutely
Okay.
spot on. Yes.
All right. So the last question we have is, which current and emerging JAK inhibitor combination strategies to be considered for patients with myelofibrosis and anemia?
Right. So I think when we think about this kind of question, we tend to think about what's new and what's coming out there, what's shiny and looks exciting. But we need to remember that we do have already some standard supportive therapies for our patients. So erythropoiesis stimulating agents, steroids, androgens, immunomodulators such as thalidomide, pomalidomide, lenalidomide can also be useful for patients either alone or in combination. And then these may be helpful then to reduce the need for dose adjustments or interruptions. Of course, in the field, we're very interested in newer agents, either as a monotherapy or in combination. Most commonly, as we use JAK inhibitors, as you know, as a backbone for many patients, we're trying to use these in combination. Then there are many of these agents used in the first and the second line. Some of these include luspatercept and imetelstat, both of which have been approved for myelodysplasia and anemia. And we do see anemia responses with these agents in monotherapy, and also in combination. There are also agents like selinexor, the XPO1 inhibitor, pelabresib, a BET inhibitor, and navtemadlin. For all of these drugs, we can see benefits in terms of spleen symptoms and indeed anemia. And then there are some other drugs that are being developed with more specific targets. So, for example, watch out for data with nuvisertib, which is a PIM1 kinase inhibitor that can be used in patients with platelets as low as 25, where we've seen benefits for cytopenic features of disease as well as splenic symptoms. There are also agents such as elritercept, which is similar in a way to luspatercept and sotatercept, which targets the TGF-beta superfamily. So that's got some data available. And then, of course, the newer mutation-specific therapies such as calreticulin, targeting agents, and more specific JAK inhibitors. Lots of new data, I think. Do you agree, Laura?
Yes, absolutely. And I think that with all this ongoing, we have to keep kind of in the first place clinical trial for treat our patients, because this will improve the options, increase the number of options for the future treatment. So thank you, Claire, for sharing your valuable insights, and also thank you to our audience to join us today. In this section, we'll be discussing JAK inhibitor selections and how can we individualize first and later lines of treatments. Let's first take a look to a clinical and patient-specific consideration when discussing JAK inhibitor treatment options with patients. So, several JAK inhibitors are now available, each with a distinct efficacy and safety profile. The key to optimizing outcomes in choosing the right therapy for the right patient, both at diagnosis and also as the disease evolves. Treatment selection should balance clinical and personal factors, including disease burden, cytopenic profile, the treatment goals as we were talking before, and the tolerance for side effects, together with the practical aspects such as transfusion needs, adherence to treatment, the access to clinical trial that we have remarked as an important issue. Some patients still discontinue therapy due to the disease progression or dose-limiting cytopenias, which highlights the need for novel JAK inhibitors or combinations to approach these patients. By integrating both the medical and the individual considerations, we can deliver a more personalized therapy, improving outcomes and maintaining the quality of life of people living with myelofibrosis. So, Claire, let's take a look at some of the clinical cases as the basis for the conversation We have a 68-year-old woman with intermediate 2 myelofibrosis. She presents with a progressive splenomegaly, significant fatigue, and transfusion-dependent anemia, requiring 2 units of blood every 4 to 6 weeks. Her blood count is 104,000, indicating a mild thrombocytopenia. What do you think are the main conditions we decided which first-line JAK inhibitor we are going to give to this patient, considering both anemia and thrombocytopenia?
Yes, so I think this is an excellent case. I think I just want to make one point, which is for me really important. This patient is in her late 60s and she's got bad disease. So she's needing quite a lot of transfusion, and she's borderline thrombocytopenic. So I really want to know for this patient, what about other comorbidities? And am I ever going to move this patient to a transplant? I just want to make that point because I often see patients and nobody's thought about that. Maybe it's the same for you, but I know today we're talking about JAK inhibitors, and transplant can take a long time to tee up, but we should be thinking about that for our patients. So the obvious things for this lady are there's a big spleen, there's a lot of need for blood, and there are also symptoms. We don't know anything about any other medical history, so I will assume that she doesn't have bad skin cancer, she doesn't have cardiac disease, etc. So looking at this patient, I know that I could give any of 3 JAK inhibitors. I could consider ruxolitinib. I know that that will improve the spleen, and it will improve fatigue, and it stands around a 15% chance of improving transfusion, but the platelet count's a bit borderline. So I'll have to start on quite a low dose of ruxolitinib, only 10 milligrams twice a day. And I will need to monitor this patient quite closely and warn her that the hemoglobin may get worse. If I'm starting ruxolitinib, I would also want to know what the baseline erythropoietin level is, because I could consider using erythropoietin in combination. And I would probably not be thinking too much about fedratinib for this lady, because anemia rates tend to be a little bit worse with fedratinib. And certainly my prescribing practice in London is limited for fedratinib. I can't use it frontline. But I could think about using momelotinib up front for this patient. And I think indeed the choice between momelotinib and ruxolitinib is the one that I would be having here. Would it be the same for you, Laura?
Yes, exactly. I think that's the 1 million question. If starting momelotinib, that will probably help these patients to get out of the transfusion dependence. And we still have the option of use ruxolitinib with and something else like ESAs or danazol in combination, dependent on the EBAC levels. But I think at least what we do here in Spain will be trying first with momelotinib, just because of the transfusion dependence. But both options are those options are available.
I definitely agree. And I'm noting that what's mentioned for this patient is fatigue. And fatigue isn't always linked to anemia, but it quite often is. And having to come to the hospital every 4 to 6 weeks is a big burden for patients. Heavy transfusion dependence and iron overload is a big significant issue. And for both drugs, we know that we can move from the JAK inhibitor to the transplant, so that wouldn't influence the decision. I think the other thing is, if let's say the platelet count's a bit lower, then I think the argument for momelotinib is even stronger then, because we start getting into doses of ruxolitinib that aren't so effective when the platelet count's sitting between 50 and 100, in my experience.
Yes. Yes, absolutely. I think that will help to the choice. So clearly, this patient needs JAK inhibition for the spleen and symptoms, because it's already on transfusion dependent. What we were talking, we can use momelotinib, or we can still consider ruxolitinib in association with other pharmacs like ECAs or danazol. So in this case, we also will consider to remit the patient to a transplant center to have that option on date. Okay.
Absolutely. We've got a plan for her then.
Yes, all set. Okay, we can now move on to the second clinical case. In this case, we are going to talk about a 59-year-old man with a high-risk myelofibrosis. And we can see that he has anemia with hemoglobin. It's a mild anemia with hemoglobin around 120 grams per liter, and a mild thrombocytopenia with 132,000 platelets. He has been on ruxolitinib for the past 18 months. Initially, he responded well, but over the time, he has developed a progressive splenomegaly, worsening of constitutional symptoms, and increasing cytopenias. With his platelet counts now down to 47,000 platelets per liter, and anemia with a severe anemia. Well, it's a moderate anemia of 85 grams per liter. So in this situation, that is something that we usually see because patients sooner or later develop these cytopenias. What tools can we use to monitor the clinical response to JAK inhibitors, for example?
Well, in my clinic, patients would all receive, we like them all to do regular symptom monitoring. Of course, we look at the blood counts and other parameters such as LDH, blood film, and of course, we measure the spleen. But by all of these measures, this patient is not doing so well. And then, of course, we also have the RR6 score, which looks at the various parameters for the patient. That's very useful for colleagues to be aware of. So this looks at, does the patient have a spleen response? Does the patient need transfusions, and have they needed them at baseline 3 months and 6 months? And then also, what about the dose of ruxolitinib? And the dose of ruxolitinib that is the target dose for the RR6 score is 20 milligrams twice a day. So that's a big dose of ruxolitinib, and this helps us to understand then what the likely survival benefit is. But I think by any of these measures, this patient is in trouble, aren't they? What would you do with this patient, Laura?
Yes, well, he's a young patient, so I don't know why he wasn't considered before for transplant, but I think this a talk we have to have with this patient. And also because he's been 18 months with this treatment, and to this moment he was responding well. He developed cytopenia, so probably he's progressing. So I think it's time to switch to other JAK inhibitor, and also taking in mind clinical trial if they are available.
Of course, we have to think about which drug might we switch to and how might we switch. So for this patient with this platelet count, at the present time, fedratinib is off the cards, but of course we expect this platelet count to be related to ruxolitinib. So it would be possible to consider fedratinib for him. But most likely we would be considering either pacritinib, if it was available, could be available in a clinical trial. The Pacifica trial is ongoing, or indeed momelotinib. Now, it's quite tricky sometimes to switch patients between different drugs, and that's something we don't always learn. But if we were switching this patient, for example, to momelotinib, how would you do that, Laura?
Well, the experience we have from the clinical trials, because we were a bit concerned about the discontinuation syndrome we were used to see when we stopped ruxolitinib. But in this case, we didn't have that problem with the direct switching from rux to momelotinib. So we don't need exactly to do a tapering and then start momelotinib. So we can do the switch straight away.
And I think your point about this man, I mean, he's under 60. We need to have another discussion about transplantation, because whilst the JAK inhibitors are very useful and we could think about clinical trials, in reality, the only curative therapy for somebody like this is a transplant. And it's not always helpful to repeatedly cycle between therapies, but we definitely need to make a change, exactly as you suggested, for him. I would want to, really understand the patient before, making that switch, possibly considering, for example, using a lower dose, making sure we've managed every single facet. For example, if there's diabetes, tightening up control, looking for folate or B12 deficiency, etc. No, I think we've made a good plan for this patient now.
Okay. So to conclude, I think we have talked a lot about this, but cytopenias, particularly anemia and thrombocytopenia, are central to the management of myelofibrosis and significantly influence both the prognosis and also the treatment decisions, as we have clearly discussed in all this with these two patients. So before we finish, I'd like to thank Claire for sharing all her thoughts about this, the management of myelofibrosis and expertise. And of course, thank you, all of you, for your interest in this important topic. Thank you.